Welcome to the Women in Wellness podcast. This is your place to get the latest up-to-date health and wellness information specifically for women, while providing you practical tools you can implement today. I'm Dr. Caitlin Sazowski, and I wanted to personally thank you for spending part of your day with me. Hello, Women and Wellness. It is Dr. Caitlin, and I am so excited about this conversation because this amazing medical doctor is talking directly to my heart and soul when it comes to teaching women about hormone balance, hormone regulation, and hopefully addressing it or understanding it to be preventative, because the last thing we want to do is constantly be reactive. Now, it's great to know and have the how-tos on how to react when we're in a situation, but if we can prevent it from getting to that point, that is the ideal situation. So today with me, I have Dr. Tara Scott, who is, I'm going to say traditional OB for 20 years, but she is also a functional medicine OB, which thank you for doing that, because there are so few OBs out there that go to the functional level to figure out the root cause of why women are suffering with certain conditions. And, you know, I'd love for you to give us the 2-minute spiel on how you became a functional doctor, because again, it's through our own typically pain that gets us to our purpose. But we're going to talk, before I let Dr. Moore introduce herself, we're going to talk specifically, women, about the different stages in life. So from menstruation, so teenage years through about 20, and then we're going to break it up into, you know, perimenopausal, menopausal, postmenopausal, and the different fluctuations on specifically estrogen imbalances, so estrogen dominance. So you guys are in for such a treat today. Make sure you stay through the end, because there's going to be so many amazing health nuggets and information that you guys are going to be able to put into play starting today. So thank you so much for being with me today. I'm so excited for this conversation.
And thank you for all you do to get that information out for your women listeners.
Perfect. So why don't you tell us how did you go from being a traditionally trained OB to a functionally trained OB?
So as you mentioned, everybody encounters their own personal struggles that leads them to seek answers. So it began, well, actually, really, it probably began as a teen. I suffered from painful periods. I had endometriosis. And when it came time to get pregnant, I had infertility and really was never able to conceive unless it hadn't been for fertility medications. Mm-hmm. So after I went through all that and then still, you know, wasn't trying to get pregnant anymore, but still wasn't feeling great, I really thought, you know, there's got to be more to this. And I've always been someone that asks why, wanting to find out, not even knowing that that was kind of trying to get to the root cause, because this was way back before the surge in functional medicine happened. I'm kind of a dinosaur when we talk about that. So I first just studied hormones and got into prescribing bioidentical hormones and hormone testing. But then, you know, once you start learning, you figure out how much you don't know. And so I had mastered the female hormones and the thyroid and the adrenal, but then I wanted to learn more about the gut and about other functional medicine things. So I did a fellowship through A4M, and I finished that. And then I got a third board certification in integrative medicine. And I just consider myself a lifelong learner.
That is what makes you an amazing doctor, because I think what a lot of doctors forget is doctor really means teacher. And the moment that we stop learning is the moment that our ability to teach goes down. So thank you for everything that you do. I couldn't agree more with you. I think I started off our conversation before we hit record saying the reason I do this, other than to share information, is because I learned so much from talking to other practitioners and just getting a different perspective or potentially a different way of thinking of things. So sorry you went through those struggles, but at the same token, it's what led you to where you are today. So that's amazing.
Yeah, I wouldn't do it any differently. If you asked me, could I go back and not have the problems that I problem? Well, first of all, I got three wonderful kids, amazing, healthy kids, terrible pregnancies, terrible deliveries, but amazing kids. I'd rather have it that way.
Absolutely. So so I know that you wouldn't do it differently, but had you have known in your teens when you first started menstruating to maybe do things a little differently, or that there was some underlying issues, what would you have done? Or what is it that you actually teach your teenage clients? Because you were indicating that you work a lot with teenagers. What do you see them come in with most often?
Well, most of the time when you're dealing with kids that age, they're either having heavy periods or painful periods, and sometimes irregular periods.
Mm-hmm.
And any of those three things, I mean, it's pretty normal. Average age of starting your periods is 12. It's about a year and a half till girls get somewhat regular. So within that time frame, it can be normal to be irregular. But after that point, they should settle into some kind of normal cycle.
Mm-hmm.
And I think the first thing is girls don't know, is it normal to change my pad every hour, and bleed through my sheets at night? There's that first part. What's normal for cramps? And, as a traditionally trained gynecologist, what happens when that patient comes in? We take a look at them. We make sure they don't have a tumor. We make sure there isn't something anatomical causing like a fibroid or a cyst. And in the absence of a pathological problem, you're only given the option of birth control pills.
Mm-hmm.
And even if that said teen is not sexually active and does not need birth control pills, they're not giving any other option. So that's kind of what happened to me is, when I finally went into the gynecologist with painful periods, and honestly, I had been sneaking my grandmother's Motrin, which wasn't over the counter at that time. And so by then I was well on my way to gastritis for taking all that Motrin for my painful periods. And then by the time I got to the gynecologist, I wasn't given any other option. I was just given a birth control pill. And I wasn't sexually active, but I took the birth control pills and had to go through 7 different types till I could get one that could control the bleeding.
Mm-hmm. So do you mind touching, because you just listed everything that I think of when a young lady starts menstruating, the complications or the discomforts, because like you said, one, we don't really talk about it. We don't typically normalize periods. It is a very normal thing, but what should they look like, right? Like, so are painful periods ever, quote unquote, normal? And I use normal very loosely because there's no such thing as normal, but should we be suffering with painful periods?
Well, right. Everybody has their own perception of pain, but in general, it should not be incapacitating. You should not be missing school. You should not be missing sports practices. So anything, and even, if you're taking a Tylenol or a Midol or an Advil here or there, that might even be okay, but you shouldn't be missing anything. So that's the first thing. You shouldn't be bleeding through. That's the next step.
Perfect. So how often should, especially a young teen, because in the beginning, like you said, it's going to be very irregular. It's not going to be very consistent, especially with like the length of time between periods and even the flow. So the amount of blood that is being excreted. But what should be expected when changing a pad or even changing a tampon? How often should that be happening? And less than that is too much.
Well, we generally say that 1 pad or tampon an hour is too heavy. I think what is normal is if you, put on some protection in the morning and you go to school and then you can make it to lunch. That's generally what I tell my patients. Can you make it to lunch? And then from lunch to dinner, and then dinner,
Mm-hmm.
And certainly we want to know if you're bleeding through at night. Most people don't have as much flow at night. Probably because you're not standing. So if it's enough that, without gravity, you're soaking, your sheets or through your nightgown or anything like that, would be significant as well.
Mm-hmm. Love it. What else might young women, because you said after about the first year, there should be more regularity within their cycle. So from day 1 of menses, so when they first start bleeding till the last day without bleeding, that can vary, right? Like what is the typical range for women's menstrual cycles to be?
So we use for teaching purposes, a 28-day cycle. And that would be day one would be the day of full flow. So if you have a little bit of spotting, that doesn't count as day one until it's full out bleeding. Mm-hmm. And the actual days of bleeding are generally anywhere from 5 to 7 days. 7 days I still think is a long time. I mean, the average would be 3 to 4 days, but anywhere from 5 to 7 can still be normal. And then after that, you shouldn't have any bleeding. There should be no bleeding when your period stops. It shouldn't be that you stop bleeding and then a week later you have a little spotting and then a week later you have a little spot. And there should be no bleeding until the time of the next period. We use a 28-day teaching cycle, but that doesn't mean everybody has to be 28 days. It could be normal, anywhere from 25 days to even really 35. If you're much more 35 or 40, you're probably not ovulating. You could be, but you're not. And certainly if you're less than 25 days, especially as a teen, there's probably it usually means there's a problem with your hormones.
Mm-hmm. So what where would you start looking if, let's say you have a 14-year-old coming in, they've got their first menstrual cycle at the age of 12, and they're experiencing really severe cramping. So they're not functioning, they're missing a day or two of school, they're not going to their sporting events, they're really incapacitated, and or they're having extremely heavy flows. What would you recommend that they start with?
So the first thing that I like to do is make the diagnosis. And so I would definitely order some traditional blood testing. I'd want to look at their thyroid. I would just want to make sure they're not anemic. And I would ask them to get blood drawn 3 weeks after the first day of their period. And that's the best time that I like to see after ovulation. Are they making enough progesterone? Mm-hmm. Because in your normal menstrual cycle, estrogen is produced at the beginning when the egg develops. After the egg releases at ovulation, the shell of the egg, for a lack of a better way to explain it, makes progesterone. And those two hormones have to be in balance. So estrogen causes growth and progesterone causes cell death. So if you have growth that's not balanced with progesterone, then you're going to have more bleeding. Estrogen is what causes all bleeding. So normally what we want to do is start with just traditional blood testing, but it's supposed to be timed at a certain time. A thyroid problem can manifest early as a teen. In the functional world, we may look at other things like candida overgrowth. And we've found some, it's probably not standard of care. You'll get a lot of different opinions, but by testing for candida antibodies in a traditional test, blood test, a traditional lab, we found that to be helpful in, helping treat patients for that. But those are the main things that we generally look at first to see if we can detect a hormone imbalance. Once we see, yes, indeed, my theory is correct, estrogen is very high and progesterone is not that high, we want to know why, right? So do they have too much estrogen because they're making a lot, or do they have too much estrogen because they're not getting rid of it? It'd be like if you came to me and you were, in debt, and I would wonder, well, what's the problem? Are you spending too much on your credit card and not paying it off, or are you just not getting paid enough? So we'd want to know the reason.
100%, because those are two very different scenarios with very different approaches on how to address it. So I love that you brought up, are they just not making enough, or are they utilizing too much and therefore they're in the deficit? So outside of getting too medical here, and because everyone's different, everyone has a different approach and everybody needs different things. After you do the testing, what is it that you recommend teens do to help with their flow, either reducing the heaviness or improving cramping? So some at-home tips or tricks that you may have suggestion-wise for these young individuals.
Well, there's a couple things that could be helpful. Castor oil packs, where it's, I think it's wool that's soaked in castor oil and put directly on the abdomen and the back can be really helpful. Supplements like magnesium not only help your body process estrogen, but also can help the cramping. And if we knew what the problem was, we would tailor a supplement recommendation. Like if there's a problem with estrogen detoxification, we could do that. If the problem is just that progesterone isn't high enough, then we can give supplement recommendations.
Absolutely. I love that. So what part of the menstrual cycle do you recommend that they use the castor packs?
So normally you can use it, and I'm not an expert on this, but before, if you knew when your period was going to start, a day or two before, and certainly during the crampiness.
The only thing that I would recommend for our listeners, if they have heavy flows, be mindful of not using the castor pack during the flow because it can make it heavier. But I love castor oil. That's definitely something that I recommend, and making sure that it's a good quality. So making sure that it's organic, because you don't want to be driving in pesticides and chemicals into our skin, especially over our uterus. So love that. And then, so outside of testing, so you said typically for teenage years, you do blood work 3 weeks into their cycle. That's typically your go-to. Is there any time that you may recommend that they do other tests, whether it be the dried urine or saliva testing in the teen years?
For the teenagers, I would most often be doing the dried urine test, because what I really want to know is I want to know about their detoxification. Are they getting rid of estrogen? And that's the best test to look at the different phases of estrogen detoxification. And the Dutch test also has some other markers on there that look at their B vitamin status and their glutathione, which are involved in the process of getting rid of estrogen. So that's the best test for this particular complaint.
Love it. And I couldn't agree more. I love the Dutch test because it gives us really an overview of everything that's happening, and where, if they aren't detoxing, where they're not detoxing, if it's like phase 1, phase 2, phase 3. So what part of their body needs that support? Because again, women, you hear me say this all the time, there's no one solution if somebody has like cramps. Depending on what's causing the cramps may require different protocols or different ways to address it in order to reduce the cramps. So would you say more times than not, when it comes to periods, especially, and this is going to be a broad statement across women regardless of their age, that it's typically due to either too much estrogen, so estrogen dominance, or too little progesterone, or both?
Absolutely. And normally in a teen, you don't have as much progesterone until the body's kind of, we call it that the axis, the brain talking to the ovaries. This hasn't matured yet. So, you see that get better when they go into college and then go on. And there's other things that can affect the amount of estrogen that you have. It could be, if there's plastics in their environment, if there's hormones in their food, if they're not eating enough of those good vegetables that are helping with detox. So those are things too that we would try to look at. But generally what I see then is if it's not always a problem, and it could be because they go off to college and they move away and I don't see them anymore, but usually the problem is solved by that.
Awesome. Can endometriosis be a problem teenagers deal with?
Absolutely. So there was just a recent article that was published that says, endometriosis is a is a surgical diagnosis right now. And should we move towards a clinical diagnosis? So what that means is the only way you can know for sure if you have endometriosis is by having a laparoscopy. And certainly in these teens, we don't want to start doing surgeries on them. So 30% of patients in that age range had also bowel issues and bladder issues. So it could be maybe they're having some bowel symptoms that are they're presenting, problems versus maybe their periods. So endometriosis, it hasn't been categorized as an autoimmune, but there's definitely some inflammatory nature. It's most often linked to estrogen dominance. Either most of the time, I think it's because it's a problem with estrogen detox. That's usually a genetic problem. People's genes for those enzymes that are involved in detox just work differently, work slower. So a lot of times that's the problem. So endometriosis is manifesting in teens, but often not diagnosed till later. Like with me, I had all those symptoms, but it wasn't until I was trying to get pregnant the second time. First time I did with Clomid, second time, then I had to do the laparoscopy that showed I had endometriosis.
Does ultrasound show the abnormal cell or lining growth in the uterus, or would that not be a means of at least potentially thinking that endometriosis may be an issue?
Yeah, ultrasound would only show endometriosis if you had what's called a chocolate cyst. So it's a cyst on the ovary that is full of endometriosis. There are certain characteristics on ultrasound that can be seen in the muscle of the uterus called adenomyosis. We generally don't see that as teens, though. It seems like, I mean, I'm not saying you couldn't, but it seems like when I was in practice, that would really be a diagnosis that we'd get in women in their 30s and 40s, really 40s.
Mm-hmm.
So it's technically not going to pick up because it's something on the surface. And ultrasound has to be a distortion of an anatomy.
Mm-hmm. Yeah, that's kind of what I thought, but I figured ask the expert since I don't look at ultrasounds at all. Okay, so teens, heavy cramping, heavy bleeding, could be a hormone problem, need to do blood work to figure that out. And then from there, have a customized approach, which may include supplementation, it may include detoxification, and it would likely include lifestyle changes to help reduce inflammation and make sure that the conversion of hormones is well balanced. Am I reiterating what you said?
Absolutely. And the other thing I'll add is that a lot of teens with acne, sometimes that's the presenting complaint, can be from estrogen dominance. Mm-hmm. And they've been to 5 dermatologists and they've tried this topical and this antibiotic and this and that and haven't been able to get behind what is the cause of their acne. And a lot of times it's estrogen dominance and a problem with detoxification then.
Mm-hmm. I love it. I love that you brought that up because I hear all the time, well, I was put on birth control as a kid because I had really bad acne.
Right.
Oh boy. Okay. So anything else you want to add about teens? So women, if your daughters are having complaints of heavy flows or not being able to function when they start menstruating, look into it now. You may be able to save them years of frustration, struggle, heartache. Speaking to 2 doctors who themselves went through it, the sooner you can address it, the happier and healthier your kids are going to be. So find a functional OB doctor, reach out to Dr. Scott, get them seeing somebody, because again, the sooner you can address it, the better everything's going to be for them long term. Next stage of life. What do we see happening like 20, so college years through 40, where it's technically considered our childbearing years, our fertility years?
Right. So that's your reproductive years. And so people who have estrogen dominance, there's usually a relative lack of progesterone, which can increase your risk of miscarriage. We call it a luteal phase defect, which just means the time from ovulation to the time that your next period is should always be fixed at 14 days. And sometimes it's not that long. You're having those shorter cycles, 21, 22 days. Progesterone is progestation. So its job is to prepare the uterus and the body for pregnancy. So if you have estrogen dominance in those reproductive years, they may not impair your ability to conceive, but it could increase the risk of miscarriage. And those are generally early first trimester miscarriages. Moving on, during pregnancy, low progesterone has also been associated with preterm labor. Mm-hmm. I had all my kids early as well. Now I know why, but I didn't then. So preterm labor can also be a reason, a result of having low progesterone.
Mm-hmm. Progesterone, women, you guys have heard me say this. This is like our most coveted hormone. It makes us feel so good. We honestly take advantage of it when we have it and then miss it when it's gone post-menopausally. Progesterone does so many things. And honestly, I bet you I could have you on here for an hour just talking about progesterone because of all of its functions. But outside of potentially the infertility or struggling to get pregnant or staying pregnant, what are some other hormone, so specifically estrogen dominant symptoms that women might be still experiencing from teenage years, or new symptoms may have arose during that age range, I guess would be the best way to say it?
So other than the continued issues with endometriosis, pelvic pain, painful periods, women can get fibroid tumors. They're more common in African Americans, but they are a result of estrogen, as estrogen causes growth. And then there's all the other symptoms that can happen, because actually after 35, the good eggs are gone. We would call you in our OB arena as advanced maternal age if you were pregnant over 35. Well, you may be done with your kids at 35 and not concerned about fertility, but that would also follow if the eggs aren't good enough for pregnancy and to maintain pregnancy, they may not be good enough to produce the correct amount of hormones. So even as early as 35, you can start having hormone issues that are going to put you back to estrogen dominance. Women at this age often experience problems sleeping. A lot of women have weight gain. Some people have hair loss, problems with hair loss as well. So those subtle symptoms that you think, I'm too young for menopause, why am I having these issues? A lot of times those can creep in over 35. Most women will come in because they're having a problem sleeping and they're really tired and they've gained weight.
Yep. You are describing most women that end up seeking help, especially around that age, because we tend to think, 35, we're still really young, we shouldn't be dealing with this, I'm just stressed out, that kind of thing. But when we backtrack and go, wait a minute, I've been having painful periods since 15, and I've been having to take Advil or Motrin or whatever it may be to get through my day, and start piecing together, maybe there is something else underlying that could be going on. So when these women come in to see you, what type of test do you do with them?
I want to just piggyback really quick on what you just mentioned. Is what you said is, when you look back, they notice they have all those things. Well, maybe the situation is they didn't have those things, and now all of a sudden they are, because you mentioned the word stress. Think about, and you don't have to be a working woman. You could be a stay-at-home mother and be totally stressed out trying to homeschool during the COVID era, or whatever, whether you're running a business from home, going to work, taking care of kids, whatever you're doing, it seems like women are stressed out more. Stress and the hormone cortisol, when it's high, will also slow down estrogen detoxification. So back to what is the best testing? We might still start with blood testing, because that way we can do the things that are best looked at in the blood, which is your thyroid. We usually look at people's sugar metabolism if they're concerned about weight gain. Cortisol had, traditionally the gold standard for cortisol testing was salivary testing, but now with this Dutch test since 2015, they have a really great measurement of the cortisol curve and also how it converts to inactive cortisol as well. So it's another great option for women who are still cycling to look at it. So it might be the same test we did with your teenage daughter.
I love it. And I love that you're talking about using different tests for different reasons at different times, because it's not like we can send a woman on day 4 of her cycle to get the blood test for her estrogen, her progesterone, maybe even free thyroid, or not thyroid, free testosterone, and really get a full picture, at least an understanding of what could be going on that might be the reason behind their symptoms. What do you do at this age to help rebalance the estrogens and the progesterones, whether it be help with estrogen detoxification, improve progesterone? What would you do in that sense?
So some of the therapies are the same, addressing detoxification, addressing diet, lifestyle changes, stress reductions. But the bigger issue is in the 40s, you could have massive swings in estrogen. And it doesn't make sense that most hormones decrease as you get older, except for cortisol. Why does estrogen go up? You would think it would go down. But when the brain is trying to get the egg to release, and the egg is old and it's hard of hearing, the brain will increase its FSH and LH, and then you have multiple eggs responding, producing estradiol. So you have an increase in estradiol over 40. So it's the same thing, but the issue is that I'm more concerned about cancer of the uterus and cancer of the breast. So the amount of estrogen unbalanced from progesterone causes growth in the breast and the uterus. So rather than naturally, sit back and wait for someone to change their stress, which, sometimes that can take a long time, change their diet, address detoxification. We still do all that, but they may need the progesterone support, like you mentioned, because I'm concerned about the lining of the uterus and the breast. And we know that progesterone does downregulate estrogen at the receptor level and actually decrease the proliferation in both the breast and the uterus.
So let me ask you this, how long do you have somebody then on progesterone? And do you do like the cream? Do you do the pellet? Like which form do you recommend? And then how long would somebody stay on that while you're working through the other things, whether it be the lifestyle, the detox, and, you know, getting to that root problem?
Those are all great questions. So progesterone is commercially available in a generic form. And all that means is it is bioidentical, but a drug company makes it and mass produces it. So you can go to Drug Mart or CVS and pick it up. And so I practice in Middle America, so it's not like an affluent area. So a lot of times we're trying to work with what the patient's insurance will cover. So that may be the first choice. It's still bioidentical, but it is made by a drug company. Mm-hmm. And so it comes in the form of micronized progesterone as an oral medication, but there are only 2 strengths. Other than that, your option is to send to a compounding pharmacy, which they make it especially for you. They can still do it orally, but more than just 2 doses. They can do any dose. They can slow release it. And so a lot of that can lead to better absorption. Mm-hmm. They can also take that active drug and put it in a topical cream. You know, some people have issues where they can't do pills and, you know, they have to use a topical cream. Progesterone itself is not available as a pellet because it's a large molecule. So estrogen and testosterone can come as a pellet, but not progesterone. So most often I will start with what's commercially available. And if that doesn't work or it's not the right dose, then we might move to an oral compounded medication. But if you've got crazy high swinging levels of estrogen, often we have to sometimes do topical and oral, because oral progesterone is just a molecule that is not absorbed very well orally. It just isn't. So, you know, if I'm giving you 100 milligrams, you're only going to get about 10 to the body. By the time your body digests it, it goes through your intestine and gets into your blood system.
Yep. So it gets broken down and.
Yep. Yeah. So topical progesterone is much, much more absorbed. Although there's not that many studies that have been done on it because drug companies are the one that fund these studies, so compounding pharmacies don't. So it's scrutinized by my traditional counterparts, but it's still very effective, a very effective tool. So your question was, how long do people stay on it? Gosh, that's a trick question, because again, it really depends on the patient. I personally started progesterone probably around 38, and I'm still taking it. I'm not through menopause yet. I have an estrogen detox problem because of my genetics, and I've waxed and waned with estrogen. It's been up and down constantly in the last 15 years. So I have had some people, if let's say stress is the main reason they're not getting rid of estrogen, their detoxification is okay, they clean up their diet, they stop eating sugar, they make sure they get enough sleep, they may be able to go off of progesterone. So it really just depends. I've had some patients that have really taken to heart and overhauled. I mean, when I started studying functional medicine, I was eating crap. I was always kind of exercising a little bit, but not a lot. I wasn't sleeping. I had to really redo all of that. So, I mean, that will get you so far for a lot of patients.
Oh, absolutely. And I always tell everybody, look, if you continue to do what got you into the position you're in, you're going to continue to struggle with it. If you truly want to have a different outcome, we got to address all aspects, everything coming in order to feel and function differently. And that's going to look different for everybody. It's going to take different amounts of time. It's going to, you know, it needs to be customized. So I know I'm asking you specific questions and there's not like a one answer that's going to be straight across the board, but just to give the listeners kind of an idea. So if you don't mind, can we talk a little bit about PCOS during this time frame? Because more and more women are being diagnosed now with PCOS, which is a form of estrogen dominance. It's also a form of insulin resistance. I like to think of them going hand in hand. You can't have one without the other. What is your thoughts on PCOS from a functional OBGYN standpoint?
So PCOS, you have to have two criteria to make the diagnosis. One is ovulatory dysfunction, which just means you're not consistently releasing an egg.
Mm-hmm.
And two is either clinical evidence, so that means high testosterone in your blood, or you can see it, like there's acne, there's hair growth or hair loss on the top of the head. That's all. You don't have to have cysts on your ovaries, and you actually don't have to have insulin resistance, but it absolutely does go hand in hand.
Mm-hmm.
So there's three theories as to what's the problem with PCOS. And they've looked into, is it a genetic problem? They've not isolated a gene or a single nucleotide polymorphism. So, but they do see that it runs in families. So there's basically three inciting incidents. The first is that for whatever reason, the brain hormones are unbalanced. The pulses that are normally releasing the egg get flipped. So LH is twice as much as FSH, LH, so there's no surge for ovulation. So that's the first theory. The second theory is, well, it's just that there's high testosterone, because the theory to support that is the adrenal testosterone, DHEAS, is high, as well as testosterone. And they say that's the problem that starts it. And because of high testosterone, you get the insulin resistance. And the third theory is that no, it's the insulin that actually starts it. You're insulin resistant. And because you're insulin resistant, it impairs ovulation. So it's kind of a vicious cycle. It's not so much important to know the why. It's more of a clinical, it's a diagnosis of that syndrome. Mm-hmm. And so, as you mentioned, because these girls get stuck in the follicular phase, which is before ovulation, that's a time where there's no progesterone produced. Because as I said, progesterone is only produced with ovulation. So they are at increased risk for endometrial hyperplasia. Now, they've never come out and said breast cancer, but that would make sense, right? Is that if they're at risk for one, they would be at for the other. Mm-hmm. So the sequela of insulin resistance that progresses is metabolic syndrome. And that would be if they have high cholesterol, high blood pressure, and an abdominal circumference, because that's where they usually hold the weight. And those girls are markedly at risk for cardiovascular events. So it's important to designate whether they've moved on to metabolic syndrome or not.
Wonderful. Thank you so much for going through the three potential causes, because it's one of those things people always ask me, what came first, the chicken or the egg? Well, sometimes we don't know, but we know that it's this, or this. And testing will tell us which one or ones it is for that individual. When it comes to addressing or helping women, and we're just going to kind of recap this age group, it's going to be similar to the preteen, whether it's proper detox, so getting rid of those estrogen metabolites, so instead of it building up in our system and wreaking havoc and causing other problems, lifestyle changes, stress reduction, and potential supplementation, whether it be with progesterone and or other supplements to either help support thyroid or support adrenals or whatever it may be. Anything you want to add to that?
And so in this age range, and depending again on the patient, you're right, there's very similar treatment interventions for estrogen dominance, but the insulin resistance, I mean, the diet changes have been seen to be as effective as metformin. So there was the diabetes prevention trial where they had people who were high risk for diabetes who only did lifestyle changes, which is diet and exercise. And there was one arm that did metformin, and they were equally as effective. So metformin is often prescribed for insulin resistance and PCOS, but even just doing this dietary changes, and there's two things that I would just say I've seen work the best. A modified paleo is one that seems to be most successful. It doesn't mean you have to eat a lot of meat, bacon and butter. It just means that you have to, you want to eat less carbs. Mm-hmm. And the second thing, the quickest thing you can do to decrease your fasting insulin is an overnight fast. Some people call it time restricted feeding. Some people call it intermittent fasting. It just means when you're done with dinner at 7 p.m., you stop eating, you don't eat again. At least 12 to 14 hours, a couple times a week for women. You don't even have to do it every day, but that's the fastest thing we've seen to decrease that fasting insulin.
Ah, yes. I tell women, and I preach this all the time, women, you can back me up, 13 hours. We want to go 13 hours every day without food. So pushing back our coffee, pushing back anything outside of water so that we're going 13 hours. And the nice thing about it is we should be sleeping 8 of those hours anyway. So it shouldn't be that big of a strain. And water, drink your water. But that will absolutely make a huge difference. And there's been research that shows 13 hours of fasting, time restricted eating, whatever it may be, reduce the reoccurrence of cancer, breast cancer, in, I think it was like, the number was uncanny. I think it was like 75%. So women, this is showing that it is helping with estrogen. So I think every single one of us should be doing 13 hours. If you have to work your way up to it, do it. But please, please, and we have a medical doctor telling us this too, time restricted 13 hours. Love it. Oh,
yeah, I agree.
So is there anything you want to throw in for the 20 to 40-year-olds?
I think we about covered it, and we kind of creeped into the 40s already, I guess.
Yep. So why don't you jump right into the perimenopausal years, the 40s through what age would you typically say?
The average age of menopause is 52. And if you look at the North American Menopause Society, the definition of perimenopause is once your cycle is 1 week late. So if you're normally 28 days and you have a 35-day cycle, that technically puts you in perimenopause. So using that definition, you could be in perimenopause for 10 years or so. So the important thing is a lot of the same thing we already talked about, but the big thing is that at this age, you can get these big swings in estrogen. And here's where we really want to be careful for breast cancer and uterine cancer. And so then shifting into 52 being the average age of menopause, I've had women stop their periods anywhere from 45 to 55, really 57 even. So it's highly variable.
And would you find that the variability will depend too on whether or not women are supplementing with progesterone?
So that's a great question. Honestly, I do not feel that, at least the way that I supplement with progesterone, it's physiological dosing, which means we never give someone more than they would make on their own. It's kind of like financial aid. You would never get more than tuition. You would just give them enough to get tuition, right? Mm-hmm. So giving those doses of progesterone doesn't stop. So you're born with so many eggs. When you run out of eggs, that's menopause. So supplementing with progesterone should not prolong menopause. You run out of eggs when you run out of eggs.
Mm-hmm. And so what would be some symptoms that women may be experiencing, during these years outside of, their periods potentially becoming longer? Sometimes it can even be shorter, where they drop down to like 21 days. Initially, what are some other symptoms that may indicate that they have an estrogen progesterone imbalance?
Well, the breast tenderness, the problem sleeping, the hot flashes, the weight gain are the biggest ones. Now, the other thing that really happens here a lot is anxiety and depression. And so those are related to progesterone shifts and estrogen shifts. So those are things that we see the most commonly at these ages, along with the fatigue as well, when your hormones drop.
Oh boy, I think you just described majority of women during that age. And a lot of times, like I said, initially it's, they relate it to stress. I just have so much going on. I can't sleep. My mind is racing. I got to get the kids from this place to this place, and then I got to do this. And it's almost a feeling of overwhelm. And so they don't know whether it's their hormones or whether it's their lifestyle or whether it's both contributing. When do you recommend that these women come in and get tested? And what testing do you recommend for these women?
I'm so glad you asked that, because I'm a big proponent of knowledge. Mm-hmm. You don't need to take hormones, maybe, if you don't want to take hormones, but you need to know what your levels are. And so knowledge is power. It helps us accomplish prevention. If you knew that everybody in your family was an alcoholic, you wouldn't drink alcohol, right? You knew that that could be inherited. So if you knew your hormones were crazy high, you would want to do what you can to prevent breast and uterine cancer. Mm-hmm. So as soon as someone's starting menstruating, check your hormones is what I would say. It would be wonderful if everyone could at 25, 35, and 45 in the absence of symptoms, like you go in and just get your checkup. I'd love for that. But in the absence of that, that's the thing. And, I'm not saying anything bad about male providers or traditional providers, but women get told that's normal. It's your hormones. And then,
or it's in your head, you're crazy.
Yeah. And it might be your hormones. That's true. And there's nothing that we can do to stop menopause. 100% of women go through menopause, but that doesn't mean going in, getting testing. You have just mentioned lifestyle, diet, sleep, all these other things, stress reduction that can be helpful. All of those things, there's free things, meditation. If you just knew, it doesn't cost a lot of money to change your diet. So
No, fasting's free.
Yes, exactly. So, and that could make a profound effect on your hormones. So I think everyone who's having any deviation, I mean, I guess if you feel great and you sleep great and you eat great and your weight is the same, if you weigh the same as you did in high school, great, then you may not need to get your hormones checked. But I think, those are all signs of people who, but women don't know that those problems are linked to breast cancer. And that's kind of what my mouthpiece is. I've been asked to speak at a lot of medical conferences about breast cancer and an integrative approach. I want to focus on prevention rather than early detection. But that's all we have right now is early detection. So, but I would say that everybody should get, and here's the other misnomer. I'm telling you, I'm an OBGYN. We didn't learn anything about this. So if you go to your OBGYN and say, I want to get my hormones checked, some of them might oblige you by getting some blood drawn. But if they don't tell you a specific day to go, if you're just there for your PAP and they don't say when was your period, or they just say, okay, let's get the blood drawn, they haven't done it the right way. They don't know what they don't know. I was one of those people. And so thankfully now with social media, with the internet, with podcasts, people can find out that there are people who do specialize in this, or people who are trained. So you can know what kind of a provider to work with. We actually have a free download on our website is what you must know about hormones. And it has a list of things to look for in a provider. This is the type of training, this is the type of person, these are the type of testing. That's a free download on our website.
Awesome. And guys, as always, the website is going to be in the show notes, and I'm going to have Dr. Scott tell us where to find her, where to follow her, because she is, I love everything that you're saying. I couldn't agree more. And I personally believe we should be getting thorough testing done at least once a year, like complete blood panels. And depending on what's going on, maybe even doing extensive hormone testing every year or every other year, depending on the unique situations, whether it be saliva and or Dutch. Would you recommend, because we were talking about this a little bit before we started, would you recommend saliva testing during this age group? Because we haven't talked about saliva testing really for the teenage menstruation years, even during our reproductive years. Is now the perimenopause where things start to shift and we start to look at testing differently, or are we still looking at it similarly to the reproductive and teen years?
So the difference with saliva testing is this: when you spit, your hormones are free. So there are certain hormone reactions that happen in what we call in the periphery. So for example, testosterone turns into estradiol, estradiol turns into estrone. That's done in the periphery. So if my 19-year-old daughter leaves the house on a Friday night in sweats and tells me she's going to go to the library, I think, wow, she's such a great kid. But then she goes to her friend's house and changes into a tank top and miniskirt and goes clubbing. I'm never going to see that because it's not in my house, right? Mm-hmm. But when you're doing blood testing, you're not going to see those important conversions that are very important for cancer prevention. So that would be one instance when I would prefer to do saliva. When you're drawing urine, and I'm involved in a study right now with the makers of the Dutch test to prove this, blood goes to the kidneys. It doesn't go to the periphery and then go through the kidneys. It just goes from the ovary into the blood to the kidneys. It skips the periphery. So my hypothesis is it really catching that conversion in the periphery like saliva does? And so the Dutch is a great test, but I don't feel like it quantifies estrone in what we call aromatase, which is testosterone to estradiol. The other instance when we use saliva testing is if you're already using a topical hormone. Think about it this way. You put a topical hormone on your skin and it goes in through the skin to the red blood cells and it's on there for about 3 seconds. But when it is time to go back to be excreted, it's going back through the lymphatics. So that'd be like if you were a UPS driver and you said, I have too many places on my route, you've got to cut it down. And I said, okay, let me look at your truck at the end of the day. And I looked in their truck and there's no packages. He would say, I've already delivered the packages. Mm-hmm. So when you are doing blood testing with topical hormones, It's not in there. It's going to be in the lymphatics. So salivary testing, I feel. Now, I do think that you can make some inferences from the Dutch test, and that's again what we're trying to quantify in this study. But this aromatization thing is best, in my opinion, in saliva.
So when would you want to be looking at the conversion of testosterone to estrogen in saliva? Like what type of female, what type of presentation would indicate that form of testing?
Well, that would be someone who, has estrogen dominance. Is it because that aromatase is active? And I've had some patients that's been the source. So that would be one of the reasons. And certainly if someone is taking testosterone or has high testosterone, you'd want to know. Anybody with breast cancer, that's very important to know as well.
So somebody with aromatase, so they're converting their testosterone into estrogen at higher rates, causing their estrogen dominance. What would their testosterone look like in blood work? Would it be low? Would it be high? Would it look normal?
That's a great question. I don't know that anyone has ever done a study, so my answer is going to be anecdotal. So I also look at dihydrotestosterone. And so dihydrotestosterone can be higher, testosterone can be lower, and estrogen can be higher. So it's usually not high in the serum and high, if aromatase is active. I had a patient who had surgical menopause who we were treating with testosterone, and we could just never get her testosterone. They were way too high or too low until I figured out she has an aromatase SNP. And that's why she's not keeping her testosterone as testosterone. She's shunting it straight to estrogen.
And what's the problem with that? Like, what is our concern with shunting our testosterone over into estrogen?
The concern is that estrone, that form of estrogen, has a higher predisposition to signal growth in the breast and the uterus. So there's 3 types of estrogen, and that particular one, if I could say one is bad, that's the one that wants to cause the problems.
And that's the one that is broken down into the metabolites that can cause DNA damage and other issues. So we really do want to be mindful.
Estradiol is also broken down during that same pathway, but estrone has a higher receptor affinity to the alpha, which causes growth.
Okay. Ladies, you just got to find a doctor that knows all this. I'm just trying to give you all the information to understand where to start looking and how to essentially figure out, is your doctor doing everything they should be for you based on any symptoms that you're dealing with? Anything else you want to add in this perimenopausal range that we haven't covered?
No, I think we've done a really great job of kind of covering a lot of stuff. Things start to repeat each other, by the different processes. And I feel like this has been a really thorough kind of podcast of covering all ages.
Okay, so how about post-menopause, menopause? Like, let's put those together because in my mind, they're very similar anyway. There's going to be some changes, but what do you recommend during that age range?
So post-menopausal, it's important to know what your body is making. I know lots of women post-menopausal that have plenty of estrogen. And if you think about it, it's like retirement. Your ovaries are like your monthly paycheck. And when you retire, you live on your savings account. If you have a lot of money, when you retire, you might be fine. You might be able to retire early if you haven't spent all your savings, right? So women, their savings account or 401k is like their adrenal hormones. And also it's just how their body processes estrogen. So not everybody needs to take estrogen. It's again, another reason why here I would like to do the saliva testing to see what your body is making, to see what you need. And then I don't even think there's enough time to go through the risks and benefits of hormone therapy at this point, but that's how we decide who should take hormones and who shouldn't, by first doing the correct testing.
And so this time you are really focusing on saliva over the dried urine test. Does blood work play into postmenopausal women?
No, because they're not producing it in their ovaries anymore. So it's not really a good way to see what they're producing. So I would probably start with saliva. And if I choose to treat someone, eventually I'm always doing the dried urine to make sure they're metabolizing whatever I've given somebody. So it seems like in the postmenopausal age, we'll usually do saliva alternating with urine.
Awesome. And I think it's really important for women to understand this so that if they go into their doctor and they say, hey, I want some hormone testing done to see where my hormones are at, and they're only offered blood work, understand that that is not going to tell you where or what you need, because just like Dr. Scott said, your ovaries are no longer producing those hormones. So it's not going to give you an accurate result. So is there anything else that you want to share on post-menopausal? Because you're right, hormone supplementation, bioidentical hormones, that would be, yet again, another whole hour podcast on it, because of all the intricacies and the ins and outs and how everybody is so different. But is there anything you want postmenopausal women to understand based on estrogen and progesterone levels specifically?
I mean, I think, I guess the issue is that really just hormone therapy, the studies that were done 20 years ago aren't applicable to all forms of hormones. And we're finding that there are unequal risks based on if it's something synthetic versus if it's bioidentical or chemically the same. So the best thing is to make sure you know your hormone levels and to work with someone who's knowledgeable about all of those studies.
So women, I guess to wrap it up, find a doctor that's going to actually test you so you know where your hormone levels are at and whether or not something has to be done to address them. Plus, then you have a biomarker to know where you are. And as you progress, as we age, we can see patterns and understand, okay, this is where you were, now this is where you are, and this is what needs to be done then. Would you agree with that?
Yes, absolutely.
Perfect. So as I like to wrap up, I'd love to ask a few just fun questions. Don't think too hard about this. But Dr. Scott, what is your favorite beverage?
I'm boring. Water.
Plain water, sparkling water, mineral water?
Plain water. I have reverse osmosis in my house, so I just bring it in. Water, ice water, cold water.
Okay. What's your favorite meal?
Gosh, I love all kinds of ethnic food. I love poke bowls. I love Korean bibimbap. I love all kinds of, I just like vegetables, I guess.
Do you have one vegetable in particular that's your favorite?
No, I like them all, except for peppers.
Oh, really? You don't like peppers?
No, I don't. That's the one food that's so good for you that I just cannot do.
That's okay. We all have one thing that we're like, I just can't get over. What is on your bedside nightstand? So what's on your nightstand?
Well, right now I have my iPad because I listen to some sleep music as I doze off to sleep from the Headspace app. And I just got a white noise machine because my husband snores terribly. So that's really helping.
Oh, those husbands. And if your husband's the reason you're not sleeping, maybe look into either mouth taping him or a white noise app. Last question. What is your favorite, like, pick me up song to get you motivated, to put you in a good mood that makes you want to dance?
I don't know if I could say that I have a favorite one, but I would say recently on SiriusXM, the Billy Joel channel is only on for so long. You know, it's like a seasonal thing. And that was my childhood. I mean, just all of his songs. We used to go to the concerts and everything. So I'm probably dating myself by saying Billy Joel. That or Broadway show tunes.
Oh, well, very cool. All right. Thank you so much. So where can my listeners find you? How can they follow you? How can they get that amazing download you have on your website?
So the website is Revitalize Med, and I think it's pretty much on the front page that you can just click to download that, what you must know about women's hormones. We also have an online course that is on that website, on the Academy. On social media, on Revitalize Med, Facebook, Revitalize Med, on Instagram, and my YouTube channel where there's lots of free videos is Tara Scott MD. There's also a free webinar on our website as well about an integrative approach to women's health.
Oh, thank you so much for doing this. I am so thankful that there are more and more medical doctors looking at, okay, what's actually going on versus, okay, here's a pill, see you later, or it's due to old age, good luck. And this is exactly what women need. So thank you, thank you, thank you. And as always, women, I encourage you to follow Dr. Scott, and I will see you next week on the Women and Wellness podcast. Thanks so
Thank
much
you.
for being with me. I hope you enjoyed this episode of Women in Wellness as much as I did. If you did, please leave a review and a rating so that others can also benefit from the information being shared. Make sure to subscribe as new content is released on Women in Wellness Wednesdays. And if you want to connect with us, go online to womeninwellness.com. That's women, the letter N, wellness.com. I look forward to seeing you next time.